Welcome to Medico Important channel. So let's continue our Mudaliar&Menon Clinical Obstetrics 13th edition series. So now we are going to look at a very important topic and also interesting topic in obstetrics, that is multiple pregnancy. This is a very must know topic, guys, so focus. So now let's first cover the definition of multiple pregnancy. So, the definition of multiple pregnancy is multiple pregnancy is the simultaneous development of more than one fetus in the uterus. So, it is the simultaneous development of more than one fetus in the uterus. So, the word simultaneous development is important. In humans, conception usually results in only one fetus. Sometimes the conception may result in twins, triplets, quadruplets, quintuplets, sextuplets, and more. So, with the increased use of assisted reproductive techniques, the incidence of multiple pregnancy is actually on rise. Multiple pregnancy is associated with high rates of pregnancy complications. Now, first, let's talk about our favorite ones, which is the twins. So, we have different types of twins. So, when a multiple pregnancy occurs, it may result from one of the two types of twinning. Okay. So, either it can be a monozygotic twins or it can be a dizygotic twins. Dizygotic twinning and monozygotic twinning, that is zygosity, refers to the type of conception. So this is very important. What does zygosity mean? Zygosity means the type of conception. Okay, refers to the type of conception. So this table is a very important question. So how will you differentiate monozygotic twins and dizygotic twins? First, monozygotic twins are uniovular, whereas dizygotic twins are binovular. Okay, so what does uniovular means? Uniovular means there is only one ova involved. Binovular means there is two ova that is involved. So what happens is, guys, in monozygotic twins there is one ova will be there and one sperm will be there. So they will be fertilized and that will divide into there will be division resulting in two embryos. That is monozygotic twins, otherwise known as identical twins. That is why they are identical, because they result from a single zygote. So one ova, one sperm will form one zygote and this zygote will be dividing into two embryo. That's why it is known as identical twins. Whereas dizygotic twins are binovular. Binovular means there are two separate ova. And these two separate ova will be fertilized by two separate sperms, resulting in two zygotes and two embryos. Therefore, dizygotic twins are usually non-identical twins. Okay, so monozygotes are identical twins, whereas dizygotes are non-identical twins, otherwise known as fraternal twins. Fraternal twins. In monozygotic twins, both the fetuses are always of the same sex. Obviously, they are identical twins, so the sex of both of the twins will be same. Whereas in dizygotic twins may be of the same or different sex. In monozygotes, if the zygote is of XX chromosome, both will be a female. Whereas in case of dizygotic twins, it may be of one boy, one girl, or both may be of the same sex. In monozygotic twins, the twins actually resemble each other. That's why identical. Whereas in dizygotic twins, the twins may or may not bear a resemblance. Like the resemblance is like just the how they within a family, how the child will be more resembling a father or a mother, that's how the twins also will resemble. It won't be exactly similar or identical. Now in monozygotic twins, the placental characteristics depend on when the twinning occurs. In dizygotic twins, there is two separate placenta, though they may appear as one due to fusion. So what happens is, guys, in monozygotic twins, there is one placenta. There is placenta number is 1. Whereas in dizygotic twins, the number of placenta is 2. This is very, very important difference. Maybe due to fusion, they may look like, just one placenta. But actually, in dizygotic twins, there are two separate placenta. Next, the type depends on the period of twinning, is very, very important. Whether the twin is a monozygotic or dizygotic, everything, the difference in which the twin will be resulting in depends upon the period of twinning. Very important, period of twinning. Monozygotic twins, the type depends upon the period of twinning, whereas dizygotic twins always are going to be diamniotic, dichorionic. This is an important point to be remembered. In short, if I have to revise it, monozygotic twins are uniovular twins, whereas dizygotic twins are binovular twins, which means this is monozygotic twins, this is dizygotic twins. In monozygotic twins, there is one ovum, one sperm, one placenta, one chorion, but two amnion. One chorion, two amnion, and it is of the same sex. Whereas dizygotic twins are of different or same sex. It is due to result of two ova, two sperms, two placenta, two chorions, okay, so two placenta and two chorions will be there. In monozygotic, there is one chorion but two amnion will be there. And it is always two chorions and two amnions. Remember, everything is 2 for dizygotic, okay? 2 ova, 2 sperm, 2 placenta, 2 chorions, 2 amnions. Whereas in monozygotic, everything will be single except for amnion alone will be 2, whereas chorion, placenta, sperm, ova, everything will be single. Now let's look at a very important topic, that is the types of placentation. So if you look at types of placentation in a twin pregnancy, it may either be monochorionic or monoamniotic. That is, there is only one chorion. Outer there is only one chorion, and inner there is one amnion and there is one placenta. Okay, there is one placenta. Yeah. If you look at this figure, it is going to be more. There is chorion is going to be only one, monochorionic, but amnion, the blue one here, see, the blue one is amnion, whereas the red one here is chorion. So in the first figure, there is only one chorion and one amnion. So it is monochorionic, monoamnionic. In the second figure, if you look at this, guys, there is one chorion, this is one chorion, but there is two amnion. So it is monochorionic, diamniotic. I'm sorry. It is monochorionic, diamniotic. Now coming to the figure number 3. It is there are two chorions. Two chorions are there as well as two amnions are there. So what it is dichorionic diamniotic, and the placenta is going to be a fused placenta. Placenta is a fused placenta. So dichorionic diamniotic. Now coming to the last figure, figure number 4. There are two chorions. There are two amnions. But see, look at this. The placenta here is fused. But in this figure, the placenta is separate. This is a figure showing a separate placenta, but dichorionic diamniotic. That's all. These 4 types of placentation is must know. First is monochorionic, monoamniotic, where there is a single chorion and single amnion and a single placenta. Next coming monochorionic diamniotic. In monochorionic diamniotic, there is one chorion but two amnion. Now next, the dichorionic diamniotic. Dichorionic diamniotic, either the placenta can be a fused placenta or it can be a separate placenta. Now talking about the period of division and outcome of division. So period of division, that is within 72 hours of fertilization. If the period of division, okay, we are talking about the zygotic division. If the zygote division is going to occur within 72 hours of fertilization, then the outcome of division is going to be a dichorionic diamniotic. Okay, so the outcome, so if the zygote is dividing within 72 hours of fertilization, then the outcome of division is going to be dichorionic diamniotic. Suppose if the division is around 4th to 7th day after fertilization, then what will be the result? Then 4 to 7 day after fertilization, then it will be a monochorionic diamniotic. Next, add 4 days. That is from 8th to 13th day after fertilization. Then the result will be monochorionic monoamniotic. Suppose the division is after the 14th day, that is 2 weeks, okay, of fertilization. After that the zygote is dividing, then it is going to result in conjoined twins. So I think you guys know what is conjoined twins, that is otherwise known as Siamese twins. It is shown in many movies also, guys. You know, I think, yeah, there is a Tamil movie also showing conjoined twins known as Matran. So if you can go guys and watch this movie where they will be showing Siamese twins. What are Siamese twins basically? So basically there are due to an embryo, it partially separates to form two individuals, but they will be connected to each other either by heart or brain. Okay, so there are two babies, they'll be connected to each other. Either there will be a single heart or a single brain. Okay, they'll be connected through the brain, like that. That is conjoined twins. So very important, how the period of division of a zygote is going to be resulting in the outcome of the division. Okay, so if the division occurs within 72 hours of fertilization, then it is dichorionic diamniotic. If the division occurs around 4th to 7th day after fertilization, then it is monochorionic diamniotic. If you add 4 days, so if the zygote will be dividing around 8th to 13th day after fertilization, it is going to result in monochorionic monoamniotic. If the division is after 14th day, then it results in conjoined twins or Siamese twins. Now let's talk about the incidence and epidemiology of these multiple pregnancy, guys. So there is a very famous rule and a very important question always repeated. What is this Helen's rule? Helen's rule states, so Helen's rule talks about the incidence and epidemiology of the twins and of multiple pregnancy. That is, twins are usually 1 in every 80 pregnancies. Triplets is 1 in 80 square live births. So 80, see Helen's rule, guys. Just remember Helen's rule. If they ask, you just need to remember the number 80. Okay, if they are asking twins, then the incidence is going to be 1 in every 80 pregnancies. If they are asking for triplets, the incidence will be around 1 in every 80 to the power square live births. If they are asking for quadruplets, then it is 1 in every 80 to the power 3 live births. Okay, this is a very famous rule, Helen's rule. Helen's rule gives talks about the incidence and epidemiology of multiple pregnancy. Just need to remember the number 80. If it is twin, then 1 in every 80 pregnancy. If it is a triplet, 1 in every 80 to power the square pregnancies. If quadruplets, 1 in 80 to power 3 live births. So coming to the factors influencing twinning. So there are many factors that influences twinning. So this is a dizygotic twins, and these are the factors responsible for causing this dizygotic twins. First is race, then heredity, which cannot be changed. Then maternal age involves a role, maternal weight, ovulation induction, or OCPs. Okay, so race, heredity, maternal age, maternal weight, ovulation induction, and OCPs. These all plays a factor these are all the factors influencing twinning. So monozygotic twins are generally 3 to 4 per 1000 births. Twinning is not related to maternal age, family history, or the use of ovulation inducing agents. So all you need to remember is dizygotic twins, these all factors which I told, the race, heredity, maternal age, maternal weight, OCPs, ovulation, these are all applicable only to dizygotic twins. Whereas if you look at monozygotic twinning, none of them will affect. None of them plays a role. So twinning is actually not related to maternal age, family history, or ovulation inducing agents in case of a monozygotic twinning. Now, what are the maternal responses in multiple pregnancy? So, talking about the maternal response in multiple pregnancy, there is going to be an increase, okay, in the pressure symptoms, plasma volume, ESR and leukocyte count, cardiac output, fall in blood pressure, body water which facilitates weight gain, GFR, tidal volume, placental mass. That is, placental hormones are 50% above the singleton values. Okay, so generally if say for a singleton pregnancy, the placental mass is the placental hormones are going to be X value. So 50% above will be more in case of a multiple pregnancy. That's what they are trying to say. Basically everything, see guys, in multiple pregnancy there the mother has to respond to not one baby, right, 2 or more babies, which means there have to be more in quantity with whatever they are having. That is, the pressure will be more, the plasma volume should be more, ESR and leukocyte count should be more, cardiac output will be more. Definitely cardiac output will be more, and there is a fall in BP because they have to manage more babies. Body water which facilitates weight gain, GFR, tidal volume, and placental mass. Definitely the placental hormones are going to be 50% above as compared to the singleton values, and there will be a decrease in hemoglobin. Yes, more, see, the mother's blood distribution is going to be to not one single baby, right? There are more babies, that is more babies, so therefore hemoglobin will be drastically reduced. That is, hemoglobin is less than 10 gram percentage by around say 30 weeks. And there is decrease in blood pressure and gastric motility, hypochlorhydria and esophageal reflux. So everything will be increased except these three things. Hemoglobin definitely will be decreased, that is around by less than 10 gram percentage by 30 weeks. There will be decrease in the blood pressure, decrease in the gastric motility, hypochlorhydria and esophageal reflux. So these are the maternal responses seen in multiple pregnancy. Now let's see how we are going to diagnose multiple pregnancy. First, diagnosis of multiple pregnancy begins with the history. First, you're going to ask for any family history of twinning. Is there any family history of twinning? That's the first question you need to remember. Then ask for the maternal age. Maternal age is a factor that influences what twinning? Dizygotic twinning, never the monozygotic. Dizygotic twinning alone is affected by this maternal age. And is there any previous history of twinning? Should be asked. High parity, guys. Yes, like the parity, the number of pregnancy, the number of times she's pregnant. If it is a high parity, if the parity is increased, then it is a high chance that she might be having multiple pregnancy. Then history of use of ovulation induction drugs. Again, this is applicable to only dizygotic twinning. So history of use of ovulation induction drug. And then the last one is pregnancy followed by any assisted reproductive techniques. So we already saw that assisted reproductive techniques, as assisted reproductive techniques are more and more, multiple pregnancies have also been increased. Okay, there's a more favoritism for multiple pregnancy because of these assisted reproductive techniques. So guys, first, how are you going to diagnose multiple pregnancy? You need to begin from the history. First, ask for the family history of twinning, and then maternal age, previous history of twinning, high parity, history of use of any ovulation drug, ovulation induction drug, pregnancy following assisted reproductive technique. So now after history, let's move on to the clinical examination. So in clinical examination, in case of multiple pregnancy, what all you can see? First is the uterine size is going to be more than that of the expected gestational age. So obviously, more than the gestational age, the uterine size will be more. And next is the fetal. There are going to be multiple fetal parts that can be palpated. Okay. So while on palpation, multiple fetal parts can be palpated. The third is 2 fetal heads in different quadrants, and at least one other pole can be palpated. So definitely 2 fetal heads will be there in different quadrants, and at least one other pole can be palpated. Now next, coming to the fetal heart rate, 2 independent observers should auscultate simultaneously for fetal heart rate, and there should be a difference of at least 10 beats per minute between the 2 fetal heart rates. Say suppose this is fetal heart rate of baby 1 and this is fetal heart rate of baby 2. So the difference between these 2 fetal rates must be at least, the difference should be at least 10 beats per minute. So we finished history and we finished the clinical examination. First we will be seeing the uterine size, that is more than the gestational age, expected gestational age, and multiple fetal parts can be palpated. There will be 2 separate fetal heads in different quadrants, and at least one of the other pole can be palpated. And in case of fetal heart rate, 2 independent observers should auscultate simultaneously, and the difference between the two fetal heart rate must be at least 10 beats per minute. Now let's move on to the investigations in case of multiple pregnancy. So what are the investigations you will do in case of a multiple pregnancy? First is the ultrasonogram. Next one is the number of gestational sacs and chorionicity. So first is going to be your USG, ultrasonogram. In ultrasonogram, what can you look for? You can look for the number of gestational sacs. Okay, see, for example, look at this figure, guys. This is an ultrasonogram and there are two separate gestational sacs. So first you can see for number of gestational sac. Number of gestational sac. In this case, there are two separate gestational sac. And then you look for chorionicity. How many chorions are there? And then you look for chorionicity. So these are the two things mainly you need to see in ultrasonogram in case of multiple pregnancy, the number of gestational sac and chorionicity. Now ultrasound assessment of dichorionic and monochorionic twinning. So let's look at the ultrasound assessment of a dichorionic and a monochorionic twinning. So in case of dichorionicity, what is monochorionicity? Dichorionicity, in case of a dichorionicity, the width of the intertwin membrane will be greater than 2 mm. Okay, so if you look, see, these are two gestational sac. Okay, in between the two in between the two twins, this is the intertwin membrane. Okay, this is the intertwin membrane. So for telling it dichorionicity, the width of this intertwin membrane should be at least more than 2 mm. And for calling it as a monochorionicity, the width of the intertwin membrane should be less than 2 mm. So this is the criteria. So if the intertwin membrane is more than 2 mm, then it is dichorionicity. And if it is less than 2 mm, it is monochorionicity. So this is the important concept you need to know, guys. And then where will you see? What are the signs you will see if it is a dichorionicity? If it is a dichorionicity, you can see the twin peak sign or the lambda sign. So this is lambda. Okay, this is the lambda. You can see for lambda sign. So lambda sign or the twin peak sign. Twin peak sign is seen in case of dichorionicity, whereas in case of monochorionicity, the sign that you will look for is the T sign, just a T. Okay, you can just see a T, and that a T sign is for monochorionicity. A twin peak sign or lambda sign is for dichorionicity. So if you look at this figure, this is the lambda sign. So this is twin A, this is twin B, and in between this is the lambda sign that you can see, or twin peak sign, which means this is dichorionicity. Monochorionicity, you can just look for a T sign. So now let's look at the placental examination in case of multiple pregnancy. So first is the number of placenta. You need to look for the number of placenta. If it is if there is two separate placenta, then it denotes what? Dichorionicity, as we already learned this. If suppose the number of layers, you need to look for the number of layers that are visualized. In dichorionic twins, there are going to be either 3 to 4 layers, whereas in monochorionic twins, there is only 2 layers. So dichorionic twins and monochorionic twins. So in dichorionic twins, there is 2 separate placenta, whereas in monochorionic twins, there is only 1 placenta. In dichorionic twins, the number of layers visualized in placenta will be around 3 to 4 layers. Whereas in monochorionic twins, if it is monochorionic twin, the number of layers will just be 2 layers. Now next you need to look for the sex of the fetus. Twins of different sexes denote definitely dichorionicity. Okay, different sex means itself it is dichorionic. Now, what are the complications of multiple pregnancy? It is a very important short note. Okay, what are the complications of multiple pregnancy? So complications of multiple pregnancy, first coming to the antenatal complications, and then we'll be moving on to the labor and third stage complications, and last we'll be moving on to the fetal complications. Okay. So what are the antenatal complications? So antenatal complications are, first one is hyperemesis gravidarum, and then we have anemia and gestational hypertension, preeclampsia, HELP syndrome. So what is this HELP syndrome? This is, this you must know. HELP syndrome stands for hemolysis, E for elevated, L for liver enzymes, and LP for low platelet count. So hemolysis, elevated liver enzymes, and low platelet count. This HELP syndrome, that is hemolysis, elevated liver enzymes, low platelet count, it is a life-threatening pregnancy complication, guys. So this is, you need to know this. And the sixth complication is gestational DM, diabetes, and then hydramnios, and the last one is pressure symptoms. Definitely there are two big fetuses and there will be pressure symptoms. So what are the antenatal complications of multiple pregnancy? There are 8 antenatal complications in case of multiple pregnancy. First is hyperemesis gravidarum, anemia, gestational hypertension, preeclampsia, HELP syndrome, gestational diabetes, hydramnios, and pressure symptoms. Moving on to the labor and third stage complications. So what are the labor and third stage complications? The first one is malpresentation. Definitely there are two big babies, say one can be breech, one can be head, or it can be anything. So first complication is malpresentation. The second complication is interlocking of twins. The twins can sometimes interlock with each other, interlocking of twins. The third one is prolonged labor. The labor duration is going to be prolonged. And the next one is cord prolapse. And fifth one is operative delivery. Definitely operative delivery is required. And the sixth one is a cesarean birth. And seventh one, postpartum hemorrhage. Eighth complication is puerperal infection and subinvolution of the uterus. So again a revision, what is subinvolution of the uterus? That is, uterus is getting back from its pregnancy size to the normal size. Okay, that's subinvolution of uterus. And the last one is lactation failure. So the labor and third stage complications are totally 9 complications for a multiple pregnancy. Okay, in case of a multiple pregnancy. So first complication is malpresentation. Then interlocking of twins, prolonged labor, cord prolapse, operative delivery, cesarean birth, postpartum hemorrhage, puerperal infection and subinvolution of uterus, and lactation failure. So you need to remember these 9 complications seen in labor and third stage. Moving on to the very important one, that is, what are the fetal complications in case of multiple pregnancy? So the first fetal complication is increased spontaneous abortions. So the fetal complication, this multiple pregnancy can lead to spontaneous abortions. There's an increased chance in of this pregnancy to become a spontaneous abortion. The second one is something known as vanishing twin. So what is this vanishing twins, guys? So vanishing twin syndrome, that is what we say. So suppose there is a set of twins. Okay, there are set of twins and or any multiple embryos. So in twins, the one embryo will die, or it can reabsorb, or it can there can be spontaneous reduction in one embryo, whereas the another embryo will be resulting in a singlet. It looks like a singleton pregnancy. Okay, that is a twin pregnancy becoming a singleton pregnancy because of one of the twin being vanished. That is vanishing twins. Third is congenital malformations. The fourth complication is preterm labor and preterm premature rupture of membrane. Very important, preterm labor and preterm premature rupture of membrane. The fifth complication is FGR, or IUGR is replaced by this term FGR. So that is fetal growth restriction. Sixth complication is discordant growth. So what is this discordant growth? Discordant growth means there is a significant size or weight difference. Okay, so there is a significant weight or size difference between the two fetuses. Okay, between the two fetuses. Say one fetus is very big and another fetus is very small. So this is what? This is nothing but discordant growth. The seventh complication is a single fetal demise. So these 9 fetal complications are very important. Let me revise it. The first one is there is a high chance of increased spontaneous abortions. Vanishing twins. Vanishing twins where a multiple pregnancy is resulting in like a singleton pregnancy. The third complication is congenital malformations. Fourth complication is preterm labor and preterm premature rupture of membrane. Fifth complication is fetal growth restriction. Sixth complication is discordant growth. What do you mean by discordant growth? Weight and size of both the two fetuses are drastically very variable or different. And then moving on to the seventh complication, that is single fetal demise. What is single fetal demise? There may occur intrauterine death of one fetus. It may be either due to a twin-to-twin transfusion syndrome or cord entanglement. The ninth important complication, that is birth asphyxia, and the last one is increased perinatal mortality. So there is a high chance of increased perinatal mortality in case of a multiple pregnancy. So we are done with fetal complications, and now we are going to move on to placental complications. So what are all the placental complications? The first placental complication is placenta previa. So what is this placenta previa? Placenta previa is nothing but placenta that is covering the lower uterus. Okay, lower uterine uterus. That implants, placenta which implants over the lower uterus and covers the internal cervical os. So it will be covering the placenta, covering the internal os, internal cervical os. So there are many types of placenta previa, guys. Therefore the placenta previa is nothing but abnormally placed placenta. Okay, so that is in the lower uterine segment covering the internal cervical os. So there are various types of placenta previa, like marginal, partial, or it can be a complete placenta previa, that is covering the entire os. The next placental complication is abruptio placenta. So what is this abruptio placenta? So abruptio placenta is one of the it is the one form of the most common, okay, it is one form, that most common form of antepartum hemorrhage, okay, antepartum hemorrhage, where the bleeding occurs due to premature separation of a normally situated placenta. So there is basically premature separation of a normally situated placenta, of normally situated placenta. So that is the definition of abruptio placenta. So abruptio placenta is one form of the antepartum hemorrhage where there is going to be a premature separation of a normally situated placenta. Now what is PROM? Premature rupture of membranes is PROM. Next, cord prolapse. There is cord prolapse. And fifth one is umbilical cord entanglement. And the last complication is postpartum hemorrhage. So there are totally 6 important placental complications in case of multiple pregnancy. The first one is the placenta previa. The second one is abruptio placenta. Third one is premature rupture of membranes. Fourth is cord prolapse. And fifth is umbilical cord entanglement. And the sixth one is postpartum hemorrhage. So these are the, we finished antenatal complications, labor and third stage complications, fetal complications, placental complications. Now moving on to the complications of monochorionic twins. So what are the complications of monochorionic twins? Specifically, I already told you, monochorionic twins, the complication is going to be very drastic. Okay, because of these complications. The first one is twin to twin transfusion syndrome. Very, very important, guys. Twin to twin transfusion syndrome. The second, as I told you, is the single fetal demise. The third complication is twin reversed arterial perfusion. The fourth complication is the conjoined twins. And the fifth complication is twin entrapment. Okay, so what is this twin-to-twin transfusion syndrome? This twin-to-twin transfusion syndrome, we can also say call it as feto-fetal transfusion syndrome or twin oligohydramnios or polyhydramnios sequence. Okay, so basically one twin is going to be having oligohydramnios. Say this twin is having oligohydramnios. And another twin will be having okay, so this is one twin, okay, and one twin is having oligohydramnios, and say the another twin, this is one sac, okay, this is one sac, and the fluid is very less in this sac, and this is the twin and this is the sac, and the fluid is very less, that is oligohydramnios in one sac. And in case of another sac, say this is the next sac, okay, so in this sac, and this is the next twin, okay, so this twin will be having there is so much of fluid, right? So this is polyhydramnios. Generally, the twin vascular is going to be, separate. Okay, each twin will be having a separate vascular structure. Whereas, because here one sac is going to be having oligohydramnios and another sac is having polyhydramnios, it results from inter-twin vascular connections. Okay, see, basically this twin is, this is the vascular connection for this twin. This and for this sac also the vascular connection is going to be the same. That is, it results in inter-twin. This is the main cause for twin-to-twin transfusion syndrome. Inter-twin vascular connections. So this is the cause. So twin to twin transfusion syndrome is basically one sac will be having oligohydramnios, another sac will be having polyhydramnios, which results in inter-twin vascular connections. Therefore, there is a twin to twin transfusion syndrome. So you know what is single fetal demise. And the third complication is twin reversed arterial perfusion. Fourth is conjoined twins. And the last one is twin entrapment. So this twin to twin transfusion syndrome is very, very important, guys. Monochorionic. So these are the monochorionic complications. You should always remember these 5 complications. Twin to twin transfusion syndrome, single fetal demise, twin reversed arterial perfusion, conjoined twins, and twin entrapment. Now moving on to this, moving on in detail about the twin to twin transfusion. So it will be like a revision. So this twin to twin transfusion is, there is arteriovenous vascular communication. As I told, there is intervascular connections, right? That is arteriovenous vascular communication between the two fetuses. So between two fetus, there is going to be arteriovenous vascular communication. So the blood is going to be pumped from the artery of one fetus to the vein of the another fetus. Okay, so from the artery, okay, of one fetus to the vein of the another fetus, the blood is going to be pumped. Say at birth, the birth weight difference between the twins is greater than 20% and the hemoglobin difference is greater than 5 gram per dl. Okay. So this is very, very important. At birth, the birth weight difference between the twins is going to be 20% and the hemoglobin difference is going to be 5 gram per dl. So there is this concept. There will be a donor twin and there will be a recipient twin. So donor twin is the one in which has the artery. Okay. And the blood is going to be pumped from this artery into the vein of the recipient twin. Okay, this is the concept. So the blood of the artery from the donor twin is going to be pumped into the vein of the recipient twin. This is the arteriovenous vascular communication seen between these two twins. So in donor twin, what are all the manifestations? IUGR, there is intrauterine growth retardation. Hypovolemia will be there. Anemia will be there. Oligohydramnios, anhydramnios, stuck twin appearance. Okay, so very, very important. See, if one twin, all the blood is going to be donating to the recipient twin. So what will happen to the donor twin? What will be the clinical manifestations of the donor twin? So the donor twin will be having IUGR, hypovolemia obviously, anemia, and very importantly, guys, the donor twin is the twin which is going to be having oligohydramnios. Okay, so oligohydramnios and anhydramnios, stuck twin appearance. Very important, this appearance, stuck twin appearance. Stuck twin appearance is seen because of this anhydramnios. Now moving on to the recipient twin. So what will be the manifestation seen in recipient twin? There will be exactly the opposite ones. Here hypovolemia for donor twin. In recipient it is hypervolemia, hyperviscosity. All will be like hyper and poly. Hypervolemia, hyperviscosity, polyhydramnios, visceromegaly, cardiac enlargement, hydrops fetalis in extreme cases. So donor twin, recipient twin in twin to twin transfusion syndrome. Donor twin is going to be having IUGR, anemia, oligohydramnios, hypovolemia and anhydramnios leading to a stuck twin appearance. Whereas in case of recipient twin, exactly opposite. Hypervolemia, hyperviscosity, polyhydramnios, visceromegaly, all the viscera will be huge, visceromegaly, cardiac enlargement and hydrops fetalis will be seen in recipient twin. What do you mean by all our revision? I already told a brief about all these things. What do you mean by single fetal demise? Single fetal demise means one fetus is going to be dead intrauterine. Okay, so single fetal demise is nothing but death of one twin, and it is associated with poor outcome. So death of one twin is associated with poor outcome of the co-twin. Okay, so one twin will die and the another twin, the outcome is going to be very poor. The co-twin outcome will be very poor. So the surviving twin, what happens is, this surviving twin or the co-twin, it has a risk of cerebral palsy. Very, very important. It has a risk of cerebral palsy or microcephaly or renal cortical necrosis and disseminated intravascular coagulation. So the surviving twin, it has the risk of cerebral palsy, microcephaly, renal cortical necrosis and disseminated intravascular coagulation. So these are the 4 risks the surviving twin will undergo. And a repeated ultrasound assessment should be performed and the surviving fetus is delivered at 34 weeks. So at 34 weeks, this surviving fetus will be delivered. So what is single fetal demise? That is, one fetus is dead. Now another fetus, that is the co-twin, will be surviving. This surviving twin will be having 4 risk of complications: cerebral palsy, microcephaly, renal cortical necrosis and disseminated intravascular coagulation. So therefore, a repeated ultrasound assessment must be performed for this surviving twin and it should be delivered around 34 weeks. Now what is twin? What is TRAP? Very, very important question. What is TRAP? TRAP stands for twin reversed arterial perfusion. So what is TRAP? TRAP stands for twin reversed, A for arterial and P for perfusion. So TRAP stands for twin reversed arterial perfusion. So it occurs in a acardiac twins. So what is acardiac twins is, amorphous mass or poorly developed head will be there and thorax with well formed limbs. So the limbs will be well formed. So these are the limbs will be well formed, whereas the thorax and the head, okay, whereas say the thorax and the head is going to be poorly formed. Okay, so this is the thorax and the head. So thorax and the head are going to be poorly formed and the limbs, okay, are going to be well formed. So this is acardiac twins. The acardiac twin, if you look at this acardiac twin, it receives its poorly oxygenated blood supply from the normal twin. Okay, so this is the acardiac twin. So this twin is the acardiac twin, and it receives the poorly oxygenated blood supply from the normal co-twin. Okay, so here you have a normal twin. So this is the normal co-twin. From the normal co-twin, there is going to be poorly oxygenated blood supply to the acardiac twin via the arterial anastomosis reversed perfusion. This is important. Via what? Via the arterial anastomosis reversed perfusion. That is why it is known as TRAP. That is twin reversed arterial perfusion. So what is twin reversed arterial perfusion? Twin reversed arterial perfusion, there is a normal twin and acardiac twin. Acardiac twin means what? Then the thorax and the head are going to be very poorly developed, whereas the limbs are going to be well developed. So what happens is, this arterial anastomosis via through the reversed perfusion will occur, and this will cause the poorly oxygenated blood to travel from the normal twin to the acardiac twin. So this is the twin reverse arterial perfusion. What is this? Conjoined twins or Siamese twin. So it is 1 in every 5,000 to 100,000 births is going to be a conjoined twin. So thoracophagous means the thorax will be attached. Thoracophagous is the most common conjoined twin. It is a MCQ, very important MCQ. So which is the most common conjoined twin seen? It is going to be thoracopagus. If there is a posterior fusion, that is back is going to be fused, then it is known as picopagus. Thoracopagus, picopagus, that is posterior fusion. If the cranium is going to be attached, then it is craniopagus, that is cephalic. And if caudally, if they are attached, then it is ischiopagus. Okay, so the conjoined twins are 4 types. The most commonest one is thoracopagus, where the thorax region they are attached. Posterior fusion means picopagus. Cephalic fusion means craniopagus, whereas caudal fusion means ischiopagus. Now let's move on to the management of the multiple pregnancy. So how are you going to manage the case of multiple pregnancy? Management during pregnancy involves frequent antenatal checkups and a calorie important, very important viva question. This is a very important viva question. What is the calorie requirement in case of a multiple pregnancy? So calorie requirement is 300 kilocalorie per day, more than the recommended one for singleton pregnancy. So more than singleton pregnancy, the recommended one, more than that 300 kilocalories suggested for a multiple pregnancy. Then rest is very important. Supplementation of folic acid and iron. Again, what is the dose of folic acid and iron? So the dose of iron will be 60 milligram of elemental iron, 60 milligram of elemental iron per day. Folic acid will be 1 milligram per day. Folic acid 1 milligram. So weight gain should be around 16 to 20 kgs. Avoid any kind of coital activity. Screening for gestational diabetes mellitus, anemia, preeclampsia should be done and must be treated adequately. So screening for GDM, anemia, preeclampsia, and that treatment must be done. First trimester ultrasound. So what will you look? Already I told you. So in first trimester ultrasound, you will look for the chorionicity, the number of the gestational sac. Okay, these two you look. The number of gestational sac and chorionicity must be seen in first trimester ultrasound. In ultrasound at 16 to 18 weeks, what will you rule out? You need to rule out any kind of congenital malformations. So in 16 to 18 weeks ultrasound, you need to rule out any congenital malformations. Then you are going to do your antepartum fetal surveillance. Antepartum fetal surveillance should be started from 28 weeks. Very important. Antepartum fetal surveillance should be started from 28 weeks. And then monozygotic twinning. In case of a monozygotic twinning, Doppler studies, okay, are carried out from 28 weeks onwards. If it is a monozygotic twinning, Doppler study should be carried out from 28 weeks onwards. Then you are going to move on to serial growth scans. Serial growth scans, okay, very important. These growth scans are used to diagnose if there is any growth restriction or any discordancy between the two twins. Okay, So serial growth scans, that is to diagnose growth restriction and discordancy. And then you're going to look for the cervical length assessment. Cervical length assessment is useful for predicting any case of preterm labor. So any case of preterm labor can be assessed by cervical length. And in order to improve the neonatal prognosis, corticosteroids are given at the appropriate time to accelerate fetal lung maturity. Very, very important. So why do we give corticosteroids? Corticosteroids are given as in case of neonatal prognosis to accelerate the fetal lung maturity. So this is the management during the pregnancy time. Okay. Now moving on to the intrapartum management. So intrapartum management, first IV line must be given. In IV line, all blood and blood products should be kept ready. And delivery IV line you give, blood and blood products should be kept ready. Delivery in a well equipped hospital. And then you are going to give epidural analgesia. After giving epidural analgesia, a skilled obstetrician and two neonatal personnel skilled in neonatal resuscitation and an anesthesiologist trained in obstetric anesthesia must be present over there. Okay, so in the OT, after giving epidural analgesia, you have to have a skilled obstetrician. There must be two neonatal personnel who are skilled in neonatal resuscitation and an anesthesiologist who are trained in obstetric anesthesia. Now a cesarean section. Okay, so if you are doing if a cesarean section should be done, and if the first twin is non-cephalic, okay, if suppose the presentation of one twin is going to be cephalic, and if the first when will you do a cesarean section in case of a twin pregnancy is if the first twin is going to be non-cephalic, and in cases of higher order multiple pregnancies like triplets or quadruples, you have to go for C-section. So when do you go for C-section? Definitely triplets, quadruplets, all that you need to go for C-section. But in case of a twin pregnancy, if the first twin is having a cephalic presentation, then non-cephalic presentation, then you need to go for C-section. In view of the high risk of intrapartum asphyxia, okay, so there is, in view of high risk of intrapartum asphyxia, the fetal heart of both fetuses should be monitored continuously. So because there is a chance of an intrapartum asphyxia, the fetal heart rate of both the fetuses should be monitored continuously. So this is the algorithm for conducting a twin delivery. Very, very important question. Okay, it can be an important short note. Okay, whatever it is, you need to memorize this table. So the algorithm for conducting a twin delivery, that is first twin in vertex. Okay, where the first twin is going to be a normal presentation. Okay, that is vertex presentation. So in the first stage of labor, you need to start giving an intravenous line, IV line. After giving IV line, you need to arrange for all the blood and the blood products. Then you need to inform the anesthetist as well as the pediatrician and get an assistant to help you, and make sure an experienced obstetrician is going to be available. So in first stage of labor, you start an IV line, you keep all the blood products ready, and then you inform the anesthetist as well as the pediatrician, and you need to get an assistant to help you and make sure an experienced obstetrician is available. Now conduct normal delivery of the first twin. Next, you need to conduct the normal delivery of the first twin, that is vertex presentation. Now, how do you do it? First, you need to clamp the cord and hand over after delivery, you need to clamp the cord and hand over the baby to the pediatrician. So as soon as you deliver the first twin, you need to hand over to the pediatrician and you need to clamp the cord. And then you need to get the assistant to palpate the abdomen to determine the lie of the second fetus and check the fetal heart rate. Now after delivery of the first twin and cord clamping and handing it over the pediatrician, what you need to go is, so you need to get the assistant. You need to call for the assistant and you need to tell the assistant to palpate the abdomen for the second twin. Okay, to determine the lie of the second fetus. And you need to check the fetal heart rate of the second fetus. If uterine contractions are inadequate, so if suppose you feel that if suppose the uterine contractions are inadequate, you need to add oxytocin to the infusion and await the uterine contractions. So oxytocin should be added and then for uterine contractions. Okay, so for uterine contractions you will be loading oxytocin in the IV infusion. Okay, now after inducing uterine contractions, you need to check the if the lie is a longitudinal lie or it is transverse or a oblique lie. So what will you do if it is a longitudinal lie? That is, with good contractions and normal fetal heart rate, rupture membranes when breech or vertex enters the pelvis. Okay, so in case of good contraction, normal fetal heart rate, normal fetal heart rupture it ruptures membranes when the breech or the vertex will be entering the pelvis. And then you need to conduct the delivery and perform active management of third stage labor. Very important. You need to conduct the delivery and you need to perform the active management of the third stage of labor. Now suppose in case it is a transverse or an oblique lie, then it definitely needs to be assessed by a skilled obstetrician, external version and the internal podalic version, external version or an internal podalic version. If internal podalic version fails, okay, excessive bleeding or fetal distress, cesarean section if necessary should be performed. Okay, so external version, internal podalic version, if version fails, okay, or excessive bleeding or fetal distress, and cesarean section if necessary. So this is the algorithm for conducting a twin delivery. So now let's look at the management of the third stage of labor. Active management of the third stage of labor with the oxytocic agent should be carried out after the birth of the second twin. Okay, so even after the birth of the second twin, active management of third stage of labor should be carried out by using a oxytocic agent or the last one in a higher order multiple pregnancy. So continuous oxytocin infusion should be given for 1 or 2 hours, after the delivery of the second baby. So after the delivery of second baby, continuous oxytocin infusion should be done for at least 1 to 2 hours after delivery. The women should be carefully observed for postpartum hemorrhage in the postpartum period. This is very important. So the women should be observed for postpartum hemorrhage. Now let's look at some certain special conditions or situations in multiple pregnancy. So what are these special situations? Now for one special situation is management of a single fetal demise, where already one fetus has been died and another surviving fetus is going to be with high risk. That is the case in single fetal demise. That is the scenario in single fetal demise. So single fetal demise is managed in a tertiary care center with access to blood and blood products, neonatal care, round the clock specialist care of obstetrician, anesthesiologist and neonatologist. So emotionally and psychological support should be given. The coagulation profile should be checked for every 15 days. In case of monochorionic twin, you need to check for the biophysical profile, Doppler velocimetry, very very important. If it is a monochorionic twin, you need to check for the biophysical profile as well as the Doppler velocimetry. And if all the maternal and fetal parameters continue to be normal, delivery is conducted at 37 weeks by cesarean section. Say suppose if all the maternal and fetal parameters are normal, then delivery is conducted at 37 weeks by cesarean section. The mother is going to be observed for DIVC in the post-operative period. So what is DIVC? Disseminated intravascular coagulation. So mother should be observed for this DIVC. Conjoined twins are delivered by cesarean section. Remember, conjoined twins are always delivered by C-section. Now the next special scenario is in case of interlocking of twins. So how will you deliver in case of interlocking of twins? So 1 in 10,000 twins with the first fetus presenting as breech and second as vertex. Okay, definitely 1 in around 1000 twins, one will be breech presentation, one will be vertex presentation. So with interlocking, see, so this is a baby of one head and this is the head and this is the bum. Okay, so there is interlocking, right? So with interlocking, there is going to be chin to chin locking. So chin to chin locking will be there. So institute anesthesia and uterine relaxation. An attempt must be made to dislodge the head of the second baby out of the pelvis and then to deliver the first twin as a breech. So this is the point here. So second twin will be delivered first and the first twin will be delivered second. So second baby out of the pelvis, the head must be dislodged. After that only you need to deliver the first twin as a breech. If this is not possible, then a classical C-section is performed. In cases of third special scenario, higher order multiple pregnancy like triplets, quadruplets. So what will you do then? Only a C-section by around 32 to 34 weeks in a tertiary care center with a good neonatal backup. So what is the perinatal mortality rate in case of multiple pregnancy? So the perinatal death rate with multiple pregnancy is 5 to 6 times higher than that of singleton pregnancy. So perinatal rate, so perinatal mortality rate in case of multiple pregnancy is going to be around 5 to 6 times higher as compared to the singleton pregnancy. Among these, the rates are higher among monozygotic twins and the second of the twins. So yeah, so we have completely finished this chapter, multiple pregnancy. So to watch more videos and more chapters in Mudaliar&Menon clinical obstetrics and to stay tuned with this YouTube channel, please do subscribe and like. Thank you.